Welcome to the Empowered Endings podcast, where you will learn how to navigate the complexities of palliative and end-of-life care in new ways. Your hosts, Dr. Bob and Elizabeth Uslander, have decades of experience raising the bar in palliative care and family support. Join us as we explore the wonders and realities of palliative care, share powerful stories, introduce you to amazing people that we've cared for, and empower you to navigate life's final stages with more grace, dignity, and ease. Together, let's discover empowered end-of-life experiences.
Well, hello there, and welcome to the Empowered Endings podcast. Appreciate you coming back to join us for this conversation about empowered endings, empowering end-of-life journeys, and improving conversations so that people have the beautiful, dignified, and gentle end-of-life journey that they want and deserve. Today, we have a special guest, and I had a chance to go on Helen's podcast in the past, and Elizabeth recently was on there, and so we have a lot of alignment in our approach and our passion about this topic. So Helen Bauer is a highly experienced hospice nurse. She's been doing hospice care for well over 15 years. She's dedicated to improving end-of-life care. She has been at the bedside for many, many people and dealing with families and all the challenges and all the beauty that comes with this career that we have chosen. So Helen, thank you for joining me. I appreciate it. It's good to see you.
Thank you. I'm tickled to be with you, and it's great to see you too. It's been a while.
Yeah, it has been. I remember our first conversation when I was on your podcast. It was such a natural flow. And I think we were able to dive into some really important topics, and a lot of it around the planning, the importance of planning and the importance of not leaving things to chance. I've been doing a series of talks that are called Conversations, Not Crises, hope for the best and plan for the rest. And I think that's a really critical approach. I'd love to hear a bit about, I think our listeners and viewers would love to learn a bit about your background and what brought you to this point in your career.
Well, I've been a hospice nurse for 15 years, but I've been a nurse for 35, which I hate to even claim because it makes me sound so old. I'm certified as a hospice and palliative care RN. I work in the state of Texas. Mm-hmm. And currently, I'm the host of the Heart of Hospice podcast. We have a library of over 560 episodes now.
Wow. Amazing.
We're getting to the end of season 10. And I also run a small business called Hospice Navigation Services, and it is basically a consulting service for anybody who needs information about end-of-life care, whether it's to troubleshoot the experience that they're having now with the care that they're receiving now, or if they're hospice shopping, wherever they are in the process, just to give them information and hopefully help them feel empowered as they go through all of this. And just on a personal note, I have a 5-year-old golden doodle who is my pet therapy partner, and I am his handler. I don't say that he's my dog, right, because we're partners, but he and I volunteer for a hospice agency. We see patients and families and staff at a hospice general inpatient facility not far from my house.
That's wonderful. That's incredible. The pet therapy is such a gift. I'd love to see more of that developing. So thank you for everything that you do. And I'm curious, when you kind of shifted into working in the end of life space and shifting into hospice care, what was it that drew you to that specifically?
You know, I'd like to say that it was a mission and a calling, Florence Nightingale, Mother Teresa. But I have to be real and honest about it. I have to say I needed a full-time job. I had been a stay-at-home mom, working part-time in home health, and I had a friend, a woman I really admired who was an LVN who said, "Hey, I work over here at this hospice agency, and we have an opening for a case manager. You should join this team. They are an amazing group of people." And at that point, my thought was hospice nursing is nursing is nursing. And it's not.
Hmm.
And I got in there and I began working with these seriously ill people, conditions, severity that I had never seen before in my career. But working in and with this incredible interdisciplinary team, learning from them, the social workers and the chaplains, and having an amazing nursing director who was my mentor. And I was hooked.
Hmm.
You look back and you think, I really didn't do anything that sparked any passion until I came to this particular silo of nursing.
Yeah.
So for me, it was a practical jump, not a calling, but now I really can't see myself doing anything else.
That's amazing. It's so sometimes it is just kind of fortuitous, right? It's the right timing, the right place, the right connection. That's how it happened. For me, I had an introduction to hospice care on a personal level 10 years after I started practicing emergency medicine, which was sort of my initial introduction to a totally different way of providing care for people that I didn't even know existed. I had heard of hospice and had a little vague sense of it, but I didn't feel it. I didn't know what it was until I had a friend go through the journey, and I was able to kind of help support him and his family. And like you, I had a mentor. I had the hospice medical director who was a friend of mine. I went down the Colorado River with him, and we had developed a nice relationship, and he kind of guided me in being able to help provide that support. And it took me quite another decade or so before I found my way into doing it. But it really is once you experience that, once you experience the incredible, I don't know, the vulnerability that people have and the relationship that you can build, and when you really give yourself to it, and the relationship with their families, and it's pretty intoxicating, in a sense.
It's very intense. And I like the way you phrased it, saying you found your way to it.
Yeah.
Yeah.
I like to say it, like you, it found me. Like I was called to this work. I just had to go through all the other sort of trainings and experiences. I certainly wouldn't have been able to do what I do now fresh out of medical school or fresh out of residency. I just think there's so much you have to experience a lot of life and a lot of different people and a lot of different traditions and cultures to be able to really meet people where they are in this space.
And if your education was like mine, I didn't receive any end-of-life education.
I'm
sure there was mention of hospice somewhere along the way, but I never had any clinicals. I didn't take a semester on death and dying, grief and bereavement, end-of-life care, and which I think is a drawback for so many nurses. So coming into it in my 40s and having all this work experience really did equip me. I had been doing community-based home health, so I had been in patients' homes, which I think is a huge culture shift. Yeah, it's a different thing from working inside a facility in a hospital. So working in home health did lay a really good foundation for me. But the philosophy of end of life is just very different.
And it's an interesting thing. I think an important reason why we're talking today is it's National Nurses Month, and we're wanting to celebrate that. And I celebrate nurses all the time. I think nurses are incredible. I've had incredible working relationships and friendships with nurses from very early on. As an ER doctor, you really count on your nurses to be very on it, sharp, keeping everything flowing, keeping you informed. And you're in this same space with them when you're doing the work that we do, when you're working in palliative care and hospice and you're working in people's homes. It's a different experience, and the relationship is different. And so the communication has to be different. And for me, the way that our practice runs, we have this really high standard for every patient and every relationship. And it's not influenced by what insurance is willing to cover or, able to cover. And the nurses, they need to totally buy into that and work at the same standard level. And it's so wonderful and gratifying for me when I find nurses out there working in this space that haven't been jaded, that haven't been burned out, that get it. And you're one of them. I can tell. There's no question. You are so dedicated to showing up for your patients and for the community. The things that you're doing to be a person who's just going to advocate for good care and help people understand what is available, how to get the resources they need. I'm really interested in the work that you're doing with advocacy for hospice, and I want to explore that a little bit further. But I want to go back a little bit to what is in your mind, in your experience, what's the value of having a trained palliative care nurse? And let's go upstream a little bit from hospice, because I think many people have an understanding of what hospice is. Some don't have a clear understanding, but people understand what that is, and less people have a clear understanding of what palliative care is. So I'd like to talk a little bit about what palliative care nursing contributes to the picture for people before they get onto hospice.
There's a lot of confusion, even among healthcare people, because palliative care really is a specialty that's sort of the new kid on the block, even though it's been around, 20 years or so.
Mm-hmm.
It's a little bit misunderstood. And I think even a lot of physicians, when a family might mention palliative care, you get this push, we're not at that point yet. We're not at that point yet. The most important thing to remember about palliative care, this is how I teach it. All of hospice includes palliative care,
Mm-hmm.
but not all palliative care is hospice. So you
expand
can have
on that. I agree, but yeah.
So palliative care you can have way before you have a terminal diagnosis, way before your illness becomes a serious illness. You can have it for a chronic illness, and it's structured very similarly to a hospice team because there's an interdisciplinary team, but you can still receive treatment. There are no limitations on that part of things. It's just an add-in. It's
Mm-hmm.
just an add-in. Unfortunately, I think most lay people who are experiencing a chronic illness don't know enough to advocate for themselves to ask for a palliative care consult,
Right.
knowing what it could contribute to their care.
Right. Once they have it, once they've seen it and experienced it, then they get it.
Right.
But if you haven't had that experience, then it's still it's this kind of vague, foggy notion of what that is. The way I like to describe it is palliative care is just really good medicine. It's just really good medical care, the kind of medical care that you would want, where you have a team of people who are focused on you and not focused just on your little disease entity or the single, disease, but they're focused on you as a person and your family system and what is needed to help make you feel better or guide you through the journey. Even if the journey means that you're just going to go on to comfort care and move into that hospice space. And I don't know what it's like where you practice, because every community is a little bit different in terms of what they have available to them. In our community here in Southern California, palliative care is pretty robust in the hospital. And for people who are fortunate enough to receive a palliative care consult or engage the palliative care team, they get the benefit of that. And so they can start having, things kind of slow down a little bit when the palliative care people get involved. They sit for longer, they talk for longer. You have different people coming in and making sure that conversations are happening and questions are being answered. But once they leave the hospital, the palliative care that's available is very sparse and underwhelming. It is not for lack of wanting it to be better. The healthcare system doesn't have a mechanism to pay for it, to pay for what's really appropriate and needed in the outpatient setting. Has that been your experience as well?
Yes, I would say it's the same here. very limited in an outpatient setting. And where I am in Southeast Texas, I'm about an hour and a half east of Houston. So it's a smaller community, and there's a lot more rural area to the community.
Mm-hmm.
I would say Houston is probably a much better resource when it comes to outpatient palliative care, but probably not this part of Texas. No, unfortunately.
Yeah, and it is unfortunate because people receive the great benefit of the palliative care support in the hospital, and I know it's frustrating for the palliative care teams in the hospital as well, because they create a plan, and it sounds really good, and they're going to be seen by these, at least here they'll get seen by a palliative care team, and they'll continue this kind of wraparound support, but they get home and it just falls by the wayside because there aren't enough providers. It doesn't pay adequately, Medicare and insurance doesn't pay for the nursing visits or the social worker visits or the spiritual counselors. So people are sort of almost offered something that's taken away from them, which I find heartbreaking, and it's frustrating.
Palliative care, in my opinion, is meant to create continuity where we're so siloed, right? Because we know our healthcare system sort of, it's in fits and starts. You'll see a specialist, you'll go to home health, you'll go to rehab, and then it's a drop more than a transition. We talk about a continuum of care, but I don't think that's a good descriptor of what we offer in the United States. Palliative care started early, is a great advocate, is a great supporter. It's a specialty, but it's a specialty for the whole person, like you were saying.
Right.
Like
and the whole
oncology
system
is strictly cancer specialty. Palliative care is specialty, but for the whole person.
Yeah.
And I think that continuity that they provide and the support that they provide can support a patient all the way through. So when they get out of the hospital and they can't, there's no mechanism to continue the palliative care, it is a real loss.
Yeah. Yeah. And it often creates this, a situation where things get very chaotic and people end up panicking because the primary care doctors, the specialists, they typically can't respond to the needs that people are having at this stage when they're dealing with the advanced cancer symptoms or heart failure or dementia. When office-based practitioners can't really navigate those things appropriately because they don't have the time or the resources. So people don't have the support, and they end up going back into the hospital, going back to the ER, going through this cycle, or getting admitted to hospice when it's not really what the appropriate level of care for them. And that happens often as well. And it happens upon discharge from the hospital, or when people make a panicky call to their doctor, and the kind of the knee-jerk reflex is, well, hospice, you go on hospice because they'll provide the support you need. And then they get on hospice, and then they find out that they no longer have access to their doctors. They no longer have access to certain treatments, and there's a different mentality that they may not be prepared for or may not be appropriate for them. So there's this big gap. And I think one of the things that you're doing clearly is trying to help people recognize that gap and not fall into it, and not fall into the sort of the chasm that can be very difficult to get out of.
Exactly.
Yeah.
I believe that an educated, informed consumer is going to get better care.
Yeah, for sure. They can advocate for themselves, and they at least they understand what might be available, what they should be pushing for, asking for. They may not be able to find it because it may not be available to them in their community, but if you don't know that it exists, then you wouldn't even know, and you'll just kind of sort of be pushed down this default pathway.
Right.
Yeah.
Which, that's not empowering at all.
No, that's not empowering.
It feels like somebody else's choices, which is exactly what it is.
Yeah. One of the things that I appreciate most about what we get to do is sometimes we'll get called in to go see somebody. Actually, after we finish this podcast recording, I'm going to go in and do this. somebody gets referred who's in the hospital, and it's clear that they're overwhelmed. The family is overwhelmed trying to make choices. The patient they've been in the hospital for the third time in this month, and they're not quite ready to say they're done, but they also don't want to continue that cycle. And they don't know what's available in their home, what resources they need. And so we get to go in and just meet with them and look at all the possibilities, all of, like, thinking outside the box, identifying what's really most important to them. What are their values? How can we make decisions and choices and support them in making choices that align with their values? And then find out if they have if the resources they have are able to meet those needs. And if not, we try to get even more creative, right? We look for other organizations in the community that could provide support or resources for people without the means. So, but if nobody recognizes these gaps, then they just get swept along, and that's where families get really frustrated and angry at the system and at the doctors and the people who kind of push them in that direction, which we try to, nobody wins in those circumstances.
It's a frustrating situation. And I have had patients that have come to me and they said, well, we told the doctor we needed more caregiving help, so they referred us to hospice. But the patient doesn't have a 6-month life expectancy.
Well, also they go to hospice. Hospice doesn't provide caregivers.
Right. And they don't actually go to hospice. That's one of the biggest myths about hospice, is that it's a place. Yes, there are hospice houses and hospice facilities, but hospice in and of itself is a philosophy and type of care like oncology or pulmonology is.
Right.
But a lot of people will come to it and say, my doctor told me that I could get more help.
Yeah.
Because I said I was struggling to care for my dad.
Right.
When in fact, we don't provide that kind of help. We're not going to put somebody in their home 24 hours a day.
Right.
Yeah.
There's a lot of misunderstanding of what hospice is and isn't, just as there is a lot of misunderstanding about what palliative care is or isn't, and even in the medical profession, because physicians refer patients to hospice and then they kind of wash their hands of them. They no longer are following those patients. They don't really know what happens to the patients after they enter hospice, because it's like this other silo that they go to, and often, not 100% of the time, but too frequently, patients and families get on hospice, and then the family realizes we're hospice, right? We're the hospice providers, because the nurses will come on some frequency, once a week, sometimes once every other week, and in certain cases more frequently. And then the other providers will come, but then they're gone. And they're available. And every hospice is different. There are some hospices that really show up fully and close those gaps for people. Many hospices don't. So, and especially now, there are so many new hospices popping up all over because it's a big business, and there are investors and private equity buying up hospices because it makes them money, and you never know what kind of quality you're going to get. So it's scary. It's scary out there in hospice land.
It is.
Which is why it's so important to have services like what you're bringing. Can you share a bit about that program that you have?
The hospice navigation service.
Yeah, the hospice navigation service. I'd love to hear more about that.
It's a service that I started basically to fill those gaps, so that patients and families feel like they're making informed decisions that are more aligned with their values.
Mm-hmm.
So for example, what's more important to you, a nonprofit or a for-profit agency? Is that a meaningful thing for you? Well, here's how to find out whether an agency is for-profit or nonprofit. Here's where you can look online. So the sessions that I do, I've never had one with a patient, someone who had a serious or terminal illness. Most of the time, almost every time, it's been with family members.
Loved ones, yeah.
Yes.
That makes sense.
Caregivers. And to do it either by phone or by video for up to 2 to 3 people. and have a conversation with them where we immediately go into, what are your questions? I have them fill out a questionnaire prior to their sessions so that I come in with a little bit of information and I don't waste time trying to get
Mm-hmm.
details and basic information. I want to come to the sessions ready to work and to problem solve. And a lot of what I do is listening because, of course, people have frustrations with their experiences. If they've got current hospice care, they want to tell me these are the nuances or these are the vibes that we're getting that don't fit well with us. What can we do about this? So I do a lot of those, not counseling, but consulting type sessions.
Mm-hmm.
And what I find is that people feel very encouraged when they have a piece of information. It's basically a tool in their tool belt, in their toolbox that they can use to provide their person with better care,
Mm-hmm.
especially folks making decisions for someone with Alzheimer's or dementia. It's a very frightening area to make literal life and death decisions
Right.
for someone else's care.
Yeah.
Signing a do not resuscitate order. There's a great deal of impact on a caregiver for that. So when you have somebody who will listen to your concerns and questions and be available for follow-up questions, I think that has a lot of meaning when it comes to empowering somebody. You get better care when you know what you're supposed to be getting.
Right. Right.
So that's a lot of what I do during navigation session.
How are you? Are you busy? Are people finding you? I mean, I would imagine that the number of people who have questions and who would benefit from that kind of communication and engagement would be enormous. How are people reaching out to you?
I do get people who book sessions, and you can book online, which is very easy. And we have hours that shift from weekday to weekday. So no matter where you live in the United States, and of course it's only for people in the U.S.,
Mm-hmm.
no matter where you live in the United States, it's easy to book a time, either early, early before you have to go to work, later after you drop your kids off at school, things like that. So there's plenty of flexibility with times.
Great. Well, that's great. We'll make sure that that our listeners have know how to find that, because that's important. And I agree. Just being able to for people who are confused and going through these really dramatic changes in their life, often for the first time, it's very scary to not have appropriate support. And sometimes the hospice team, the nurses, the social workers, the spiritual counselors are responsive and give them that sense of comfort and connection. And often they don't. Often it's new nursing grads who don't have experience with hospice and don't really understand how to do that, or people who have been working for too long and are just kind of at the tail end and burning out, and they have to all the documentation, and there's so many challenges. So for someone to have a safe space that is unbiased, that is is there really for them, for that purpose, is really important. I just recently had a patient who was clearly in her final days or weeks of life, an elderly woman with metastatic cancer who was on hospice care, and they were referred to us because she was interested in pursuing medical aid in dying, which is not legal in Texas, so that's something that you don't deal with a whole lot. But when I went to meet with this woman, it was clear that the family was overwhelmed and incredibly frustrated with their current hospice experience, and the people weren't calling them back. They hadn't ordered appropriate medications, and when they did, they never showed up. There was just on every level, this hospice was missing the mark, and it was escalating to the point where this family just they didn't know what to do, and they were so dismayed, because what it was causing was their loved one to suffer and not have the right medications and not have the right support. So unfortunately, the woman wasn't able to pursue medical aid in dying because she was too far along, and she wasn't able to make her wishes known. But what we did is we made it, we changed hospices. There's a few hospices that I work with pretty closely, and I know how they work. I know the level of care they provide, and even though it's sometimes a little bit complicated to make that transition, especially when there's only a short amount of time left in the person's life, we made the transition. A new hospice started. The patient died later that night, and I talked to the family the next morning, and they were so grateful that that she actually died under the care of people who they felt cared about her. And they had a couple of conversations with nurses, the admission nurse, and then somebody came out to and they got the right medications to deliver quickly. That relationship, even if it's only a matter of hours, can be so important. And in that stage of life, it's so common to hear about hospices that just do not show up for people, and it breaks my heart because I know what's possible, and when we see it done well, it has such a transformational effect on the loved ones, and when it doesn't go well, they live the rest of their lives with regret and guilt and, in a sense of trauma around that experience.
It's what I call a death legacy.
Yeah.
You
Yeah.
know
That's
what? Because they're going to remember how that hospice cared for their person and for them at the same time for the rest of their lives, and
for
they're going
sure.
to tell other people about it. And it unfortunately paints us in a terrible light. But there are hospices that are neglectful and they make mistakes and they just get things wrong. I'm glad that you highlighted this thing about changing hospices, because that's one of the things that I talk to navigation session clients about. Is you have the right to change an agency if you want
Right.
to, but hospice agencies need to remember that it's exhausting and time consuming for a caregiver to have to make that decision and make that jump. The fact that that family you worked with was willing to make the jump that late in the dying process is an amazing thing. Most people would be scared to do that. They would just stick it out and then have this added grief burden of feeling guilty, like they didn't do enough and the care
Right.
was bad and the death was bad.
Right.
But because they advocated and moved forward with it, it's courageous. I think it's a brave move. It takes a lot
I
of
agree.
courage to do that.
Well, and
But
you can only
it's
do
just a
it. Oh, sorry.
challenge.
You
No,
can
go
only
ahead.
really do that if you have an advocate, if you have somebody who's going to help kind of be with you through the transition of it,
Right. If
because
you don't
otherwise you
know
wouldn't
that you can
know.
do that, yeah, you'd never ask.
Yeah. And then you don't know if you're going to get anything better. You don't know which organization to go to. You would kind of imagine you'll get the same. Hospice is hospice. And so there's
Right.
so much need and opportunity for educating people, and that's a part of our shared mission, I believe. So I look forward to continuing on this journey of educating and supporting and and collaborating in any way that we can. Is there, if you were to, like, I don't want to put you on the spot too much, but if you could think of like one thing that you would tell families who are sort of in the journey of considering palliative care, considering hospice, like how would you suggest that they educate themselves or get the information they need and try and do what they can to minimize the damage and increase their chances of having a, a positive supported experience?
I would tell people there are resources out there and there are organizations out there who can support you. If you sit back and let it happen, you're probably not going to get the best care. So being an advocate, which does not mean being aggressive or being a jerk, verbally abusive and being and complaining, that's not being an advocate. Going out and getting the information you need, asking the questions. I would tell people, don't be afraid to ask again. Don't be afraid to ask more than one person. If you need to shop for an agency, shop for an agency if you have the luxury of time.
Yeah,
So many
right.
people don't. So many people don't. But if you have the luxury of time, it's okay to shop and it's okay to ask questions. There are websites like caringinfo.org. Caring Info has all this information for people who are having to figure out and navigate hospice care. Download the checklist and ask the questions. Interview people like you're giving them a job, because you are. They're going to work for you. I think it's also really important for people to know they're part of that team. When we talk about an interdisciplinary team, the caregiver's right in there. You are the expert in your person. And the hospice team needs you to function well to give your person the best care. I would also tell people, don't be afraid of that whole interdisciplinary team. Don't let that team, that word interdisciplinary or multidisciplinary, scare you. A palliative care team covers mind, body, spirit. So they have people who specialize in the care of mind, body, and spirit. And you need all those different disciplines to take care of your person and to take care of yourself.
Yeah. Awesome. Advocating. I think advocating is the key. Finding, if you can't advocate, some people can't advocate for themselves, so they need others to be there to advocate for them. And advocating and education, right? And what happens so often, unfortunately, is people just get pushed down this path, especially when they're in the hospital and they're getting ready for discharge. And it's just the easiest way to get somebody out of the hospital is to get them on hospice. And the easiest way to get them on hospice is to refer them to a hospice agency that as a case manager or discharge planner. So people have to sometimes be you have to be a little bit bold and sort of slow down the process in the train, even though the forces are not in your favor, because they're trying to get you out of the hospital and they're trying to get you down this particular path. You need to, in order to have the best possible experience, you need to make sure that you're like you said, you're considering what your needs are, making sure that you feel comfortable with the responses for the organizations that you're kind of interviewing, and if something doesn't feel right about it, if you're hitting walls or finding that you're not being, that the responsiveness isn't good, don't let it go on for too long, right? Like
Definitely.
Advocate, and because the further down you get into that chasm, the harder it is to climb out of it.
It is. Once you get into the hospice care, if it's not a good fit for whatever reason, it's so much energy to figure out where you need to go from there.
Yeah. Well, I appreciate you. I applaud you. And I look forward to, again, further collaboration between our organizations. And as we continue to kind of move this mission forward of improving end-of-life care for everybody. So, Helen, thank you so much for being on Empowered Endings podcast, and thank you so much for the work that you do. And I look forward to our future conversations and collaborations.
Thank you, Bob. It's been a pleasure.
Yeah. Take care. Thank you, everybody, for tuning in, and we look forward to connecting with you again soon. Thank you for joining us today. We hope you found this episode to be valuable. Having tough conversations about how you want to experience the end of life is so important. And please share this podcast with someone you know who needs to hear it. We're all in this together. For more resources and support, please visit empoweredendings.com. Until next time, remember that every ending can and should be an empowered one.